All right, so this is Pharmacology 1. We're really going to be using a lot of the topics that we refer to in pharmacodynamics. So you guys remember all the details from pharmacodynamics, right? Every single one of them. So all the stuff about absorption and distribution and metabolism, all those things will still come up through here. We'll see how they'll kind of relate to individual drug examples. So I like this class a lot better because I can actually relate it to actual drugs and kind of teach you how you might be using some of these substances. We went over the lecture schedule already, and then also your top 200 drug list. Again, we're going to have 3 exams. You need at least a 75 in order to pass that, and each one will be a 50-question multiple choice test. Again, I'm not trying to trick anyone with any of the questions out there. It'll be pretty straightforward, similar to the pharmacodynamics exam. That might be subjective. I thought they were pretty straightforward, but some people might have thought otherwise. And again, test questions will come from any aspect of the drugs that we talk about for this section. As far as the objectives that we're going to be covering, and the objectives are going to stay the same throughout the entire course. I'll kind of cover it this time and won't really belabor the point too much. But one, we're going to be talking about the basic pharmacokinetic processes, right? So that's our absorption, our distribution, our metabolism, and excretion, and a lot of the factors that may alter that, whether it be disease state interactions, whether it be drug-food interactions, things like that may affect any of those aspects of pharmacokinetics. We'll look at the concept of and potential for drug interactions and how those pop up. We'll look at some of the rationale for how we're going to use these drugs. So why one drug might not be good in this situation, but it might be perfect in this other situation. We're going to look at kind of individual drug unique aspects of it that make it more suitable for that decision. We'll look at some of the significant adverse reactions. I'm not going to cover every single adverse reaction that's possible, because again, if you look at a package insert, it's going to, it's like 10 feet long, right, of every single adverse effect that's ever been reported for a drug, right? We're talking about the significant ones, the ones that are clinically relevant, you should be on the lookout for when you prescribe these medications. And then how to actually intervene when you start to notice some of these interactions coming up. It could be a simple dose change, or it may need to stop the drug completely, depending on what the interaction is. We'll look at bioavailability and bioequivalence of various drugs. You guys remember talking about bioequivalence. What does that mean for bioequivalence between 2 drugs?
The same dose, they do the same thing.
Yeah, so it's the same drug, same strength, same potency. They have to be able to show that, this goes for generics and versus brand name drugs, where you give a drug and you're looking at the pharmacokinetic parameters, and they have to be exactly the same, or at least within a certain tolerance for a drug to be considered bioequivalent between one another. We'll look at the indications, the rationale, and the mechanisms of action for these agents. This will be a big some of the big things to remember, especially when you're, people ask me, like, how was the best way to memorize all this information? The best way you can do is try to classify and kind of store things into different containers. So say, for instance, you're looking at something like, cephalosporins. Like cephalosporins go into this container because they all share the same mechanism of action. They all share these certain characteristics. I know them by, I can read a drug and I know that it's a cephalosporin based on these naming conventions. Those things, try to categorize things into big buckets, and then you kind of learn the unique aspects of them as you drill down further, right? Because I only have 50 questions, it's going to be really difficult for me to ask and these really pinpoint questions on every single drug. A lot of times you may be looking at more kind of broad questions where you're more looking at things like mechanism of action or common food-drug interactions, things like that, rather than what specific isoenzyme of a CYP enzyme is this drug affecting and how, things like that. So in general, memorize the concepts first and then kind of drill down and get to the unique aspects later, if that makes sense. We'll look at some of the differences between the pharmacodynamic mechanisms and their physiologic responses, because remember, pharmacodynamics is what? So what the body does to the drug? No, right? So what the drug does to the body, right? So that's really going to be what the mechanism of the drug is and how it's going to elicit its physiologic responses. So we're going to look at the dynamics of it. We're also going to look at the kinetics of it as well, as we already described. We'll look at any pertinent patient education aspects. Things that are really important to tell patients to look for or to be monitoring for, to either look for effectiveness or look for toxicities. Things like, if you're on a blood thinner and you start to notice abnormal bleeding or bruising, like that, there should be a warning sign. It should let you know to come in and get checked out. You check your INR or whatever happens to be. We'll look at different things like, considerations for selecting correct dosage forms, the actual dose itself, the route of administration, because you'll see that in certain cases, one route of administration might be contraindicated for a patient, or it might be better for one versus another, and how that's going to pertain to your patients. And then also look at, some of the components for correctly written prescriptions. So some of the things you should make sure to indicate on your scripts to make sure that they are going to be filled as you intend. Because again, having kind of a poorly or half-written prescription is just, just rife for error to occur and have some medical mistakes happen. Again, based on the different disease states or different systems we're going to cover, we'll look at the clinically important agents. Certainly I can list every single drug under a certain category possible, some that haven't been used in like 60 years, but that's no good for you guys, right? Because that's not really clinically relevant. So I'm really going to focus on the ones that you're more likely to see in your clinical practice. Now, if you go to, say, work in a surgical setting, are you really going to see a whole lot of hem-onc drugs? Probably not, but if you were to work in a hem-onc type setting, I'm going to focus on those drugs. So again, it may not be pertinent to you when you get out into actual practice, but if you go into those specific areas, those are the things you might be seeing. We'll look at the clinical applications for each drug class. We'll talk about the specific pharmacokinetics for those different classes, and then look at those side effects and manifestations of toxicity. And then look for any contraindications. And so we'll focus on things like absolute versus relative contraindications. And obviously an absolute contraindication means what?
Never ever give it to.
Yeah, you would never ever want to give this drug to this person. Versus a relative contraindication would be something like, well, you probably don't want to give it in these situations, but it might not always be applicable to your patient, right? So something that has really bad teratogenic effects, obviously that would have a absolute contraindication for a pregnant patient, but maybe for everyone else, say males or anyone of non-childbearing potential, like maybe just a relative contraindication. So focus on those as they come up. Okay, so again, when you're going through, we're going to be looking at, and I may not list every single aspects of these drugs for every single one, right? So you should have knowledge of basic mechanisms of action, the indications for use. I'm not going to be exhaustive and list every single possible medication for indication for use. Certainly list some more common ones for a specific drug, right? So maybe some of the off-label uses, but I try to focus on really the big indications there. And again, look for monitoring, follow-up. How do we monitor for toxicity and efficacy? And then also, how can we, looking for chances for reducing medical errors? How can we do that with looking at the different drugs and the different aspects of them and how we use them? And then obviously with allergic reactions, we're going to talk a lot about those, especially in relation to antibiotics and things like that. How can we recognize them? How can we treat them? We'll go from there. Okay, so if you were to try to, as a kind of a study guide to help you guys out, because again, there's a lot of medications we're going to cover. Some people really find it useful to make flashcards, and there's some commercially available flashcards out there that has a lot of this information. But these are the main things that you would probably want to make note of. And again, for every single drug, I may not list every single one of these. So things like overdose information. Well, for a lot of drugs, there may not be any really clinically relevant overdose information available, right? Or may not really be clinically pertinent. So I may not list that for every single drug, right? I'll list really the important things, and so those are the things you want to make note of, things that are possible test questions. And again, this class is not going to be the end-all of pharmacology. I am certainly fallible in many ways. I've probably already said a couple wrong things as it is. But in the real world, make sure to use your references. Always double-check yourself. Take a few extra seconds to stop and say, like, is this the right drug? Is this the right dose? All these different things. Look at your guidelines. Obviously, those are going to be the most up-to-date, most pertinent information for you. So, if you're treating something like acute otitis media, go look up the IDSA guidelines on that. The Infectious Disease Society of America. Go look at the guidelines, because that's going to have the most absolute up-to-date information possible. Obviously, once you start to get from the primary literature, secondary literature, get down to the tertiary with the textbooks, that information may be somewhat dated. Working off of Goodman and Gilman's, that edition was put out in 2012. It doesn't have a lot of drugs that have come out since then. So, you have to be aware of those changes that have happened since then. So again, guidelines are great. Textbooks are also good. And obviously your online references. So what are some online references you might go to for drugs? Merck. Okay, Merck might be one good option. So they put out like an online drug manual. It'll give you some information. That one's not bad. FDA has some good information, especially if you're ever worried about drug recalls. They have a lot of information that comes out regarding that. Sometimes they'll have kind of special topics that will come out from the FDA. There's actually a good one just recently where they actually took liquid docusate. Basically, they did a major recall for all liquid docusate products. Docusate's a laxative product, a stool softener. And basically what they were seeing, they're having these isolated cases of Burkholderia cepacia in these patients that really shouldn't be getting it. So Burkholderia cepacia is really a drug or an infection you really only see in patients who are immunocompromised, CF patients, things like that. They're popping up in patients who are just happen to be on a ventilator, right? So they're popping up rare cases and they actually were able to trace it back to that docusate being the probable contaminant, right? So sometimes FDA is really important for good drug releases like that. Any other references you guys would use? Like Up to Date maybe? You guys ever use that? No? Up to Date is really good. No one's ever used it? Okay. You guys have access to it through the library, but UpToDate is really good. So UpToDate is nice because of the fact that it'll give you, so say you're looking up acute otitis media and you want to see what they recommend as far as treatment goes. Those sections are written by kind of content experts. So you'll have a lot of physicians who work in that specific field who are writing these things. And so the one thing you got to remember with UpToDate is it's kind of like Wikipedia, and the fact that it's kind of individuals writing it versus it really being a group. They have editors and things like that, but sometimes you'll have personal opinions kind of creep in, or this is what the guidelines say, but this is what we do clinically. And so sometimes if you're practicing absolutely evidence-based practice, UpToDate might get you in a little bit of trouble with that, but just remember there is some personal authorship there. There is some opinion that will leak into UpToDate. But in general, if you need a good overview of a topic, especially on how to treat something, that one's a really good reference to go to. Just make sure you never reference in like a project or something UpToDate, because it's like referencing Wikipedia. You don't want to do that. Friendly pharmacists are always good too, so if you're ever out in clinical practice, always ask your pharmacist if you need any help with anything. Obviously, we respond pretty well to gifts. Refer to your specific pharmacist for what they like. And then a lot of things with the medications we're going to be looking at here is that you guys want black and white answers for everything, right? If I've got the patient that has this disease state, this is what the drug I want to use. You may not always get that 100% black and white answer. There's always lots of shades of gray. And if you ask me a lot of questions, I'm probably going to come back with, well, it depends, right? Because in a lot of cases, it depends on what type of patient you're treating, what type of insurance they have, what type of other disease states that they have. Do they have problems with being adherent to certain medications due to whatever reason? So keep in mind, there's always going to be some gray to these. To whenever you're making a drug selection, there isn't always one absolute best answer. Sometimes there's going to be multiple answers. And again, if anything doesn't look right, always ask a question. If you see an order, you're like, that really doesn't make any sense, just stop yourself and ask a question, because that's how you can prevent really significant medication errors from happening, whether it be a drug given via a wrong route, or whether it be the wrong drug in the wrong patient, things like that. You really got to be able to take a step back and say, wait a second, let me figure out something wrong here. Okay, so the first section we're going to cover is going to be ophthalmology, and we're going to go over a little bit about dosage forms to begin with, since we didn't really cover that too much in pharmacodynamics. So this is going to be really exciting for you guys, but comparisons of different dosage forms. So these are some of the topical dosage forms you're going to run into somewhat frequently. So we have ointments, creams, we have lotions. So what's the main difference between ointments, creams, and lotions? What would you guys say? Kind of the feel. So I hear some people like it's kind of the feel of it, right? A lot of it has to do with kind of the viscosity and the makeup of the product. I always feel like females have a little bit better idea of the differences between these than the guys do. I had no idea when I was going into pharm school. Like, I don't know, ointments, creams, they're all the same, right? So one of the things we'll talk about with these different products is how occlusive they are. And so obviously occlusivity is going to be how well they kind of stay put where they're at in order to occlude whatever kind of topical site they're put on. So ointments usually are going to be a semi-solid emulsion. Usually the majority of it is going to be oil, either petroleum or lanolin based, and then water kind of being the minor constituent there. Again, the main ingredient is going to be oil for these, and these are going to be the most occlusive. And if you, how would you describe the feel of an ointment?
Greasy.
Yeah, oily, greasy, like that's how you would describe it. But the reason that it's so good at being occlusive is that greasy nature to it. It likes to stay there right where it's at. It's hard to wash off. It's going to have a lot more staying power, which might be better for some situations where you need something that's going to be able to stay on there for a long period of time versus something that gets washed away a little bit more easily. Then we have creams, which is going to be kind of more closer to more of a 50-50 type mixture between oil and water base. So again, still an emulsion of oil, but again, water is going to become a much more major constituent here. So again, the occlusivity of it's going to be lessened. It's going to be less greasy. It's going to be able to wash away a little bit more easily, but it's also going to be more easy to apply to the skin. It's going to be a little bit more more runny, so to speak. It's a little more easier to apply. And then lotions are going to have just almost all water base, and so those are going to be the ones that are most easily washed away, have the least amount of occlusiveness to them. So again, just to look at the comparison of them, if you're looking at ointments, obviously the feel is going to be pretty greasy with them, and then you get less and less greasy as the water content goes up between those. As far as the appearance goes, ointments tend to be typically more clear in general, unless there's something added to it to prevent that. With creams and lotions getting more opaque or milky kind of in appearance. And then obviously the consistency is going to be more firm as you get with the ointments, and then as you get the water content going up, again, more liquid in general. And then the way that they're actually dispensed is going to be changing based on their physical properties. So again, with an ointment, with it being much more semi-solid, a tube makes more sense for dispensing that versus something like a bottle, how you get lotions out of, right? Because again, if you had like a lotion that was in a tube, it'd be really easy for most of it to kind of fall out because it's so runny, right? And then moving on, looking at the difference between solutions and suspensions. Solutions are obviously going to be drugs that are in an aqueous base. Typically it's either water or saline, and it really doesn't require mixing. Even if you leave it standing for a year and you come back, because it's an aqueous solution, it should still have drug kind of mixed in equal parts all the way throughout the entire solution, right? And these are going to be ones that are really suitable for IV administration. Now, why don't you think we'd want to do a suspension in an IV administration? Okay, yeah, so if you look at the particle sizes between solutions and suspensions, suspensions are going to be have a lot bigger particles in them, and that's why they settle out, basically just due to gravity. You see a lot of drug products, especially oral products, that be suspensions, and if you give it enough time, depending on the kind of vehicle that it's in, it eventually will settle out. And because of those big particles, if you were to inject that intravenously, what do you run the risk of? Having embolism, absolutely. So you run into that same problem when you have something like IV drug abusers who crush up things like tablets for injections. Have you ever heard of like someone crushing like oxycodone or hydrocodone, something like that, and injecting that? Oftentimes, due to the other excipients that are in the tablets, things like the talc and other things, they actually end up developing pulmonary problems later on down the road because they inject it chronically over time. All these little talc emboli start to build up, and you can cause some fibrosis there, right? So again, suspensions are never going to be good for IV administration. You can do it intramuscularly, right? Because you're not worried about it getting into the bloodstream. The drug can kind of slowly dissolve into the bloodstream, but you don't really get those big particles sitting in there that can cause the emboli. The reason why something may be a solution versus a suspension, a lot of it has to do with the drug solubility and also the base solution that's being put in. So depending on how polar the product is, depending on the pH of the solution you're putting it into, it may or may not be that easy to get into solution. So we'll talk about some examples of that where that can be a problem, especially with IV solutions. But again, with suspensions, it's really important that we shake those up before use to make sure we have the drug being mixed all the way throughout, to make sure we don't have any issues with the drug concentration changing throughout. And actually, one of the big problems with this that I saw clinically come up, I had a patient who was having these, the child basically was on phenytoin. It's an anti-epileptic, and phenytoin comes in a suspension. And the mom was saying, well, he's having all these problems, he's having all these breakthrough seizures, and then all of a sudden she gave a dose, and the kid was completely snowed, completely out, couldn't wake him up. So I brought him into the emergency department, and they're trying to figure out what the heck happened. And so what actually happened is that the mom never was told to shake up the product before giving it. So what had happened was the solution that the kid was getting at the top had almost no phenytoin in it, meaning that he was going to be having more seizures. And then at the very bottom, all the phenytoin was there. So then all that drug got given at one time. And then, of course, he's going to be totally zonked out because that's what the drug does. It kind of inhibits, the brain from firing. So that's, a very important side effect from not actually mixing up the bottle appropriately beforehand. So again, it's always a good thing to let your patients know about. Shake up bottles beforehand. Make sure things get adequately suspended throughout the solution. Again, just a visual representation of the particle size between solutions versus suspensions. Again, just due to the force of gravity, those bigger particles are going to eventually fall out into the bottom. Okay, so looking at different types of solutions, again, these are going to be homogeneous solutions, or the drugs are going to be mixed all the way throughout. But in order to do that, you may need different vehicle bases, and so this is where you'll hear some of these different types come up. So syrups are going to be typically concentrated aqueous preparations, but they're going to have a high sugar content. And again, sometimes they'll have flavorings added to them, maybe not. But again, these syrups are typically going to have a high sugar content and will help to dissolve the drug, essentially. Some issues that can pop up from giving syrups, and a lot of these you'll see issues with more pediatric patients, because again, they have a hard time swallowing tablets and capsules, so they use a lot more oral preparations. But giving a syrup, if you have a patient who, say, was on a ketogenic diet, say they have really, really intractable epilepsy, and they put them on this ketogenic diet to help prevent seizures, they really can't receive any type sugars whatsoever, otherwise it's going to knock them out of ketosis. And so if you give them a syrup and you don't actually look at the drug beforehand, you may be interfering with their epileptic treatment by giving them this other drug that happens to be in a syrup. Again, so it's important to look at your dosage forms to see what the contents are before administering it. Alcohol is also a formerly more important constituent for a lot of these solutions. So when you see elixirs or tinctures, typically those are going to be hydroalcoholic solutions, meaning they're going to be water and alcohol mixed together. So you'll see certain drugs, like even things like NyQuil. If you look at NyQuil, it actually has some alcohol content into it. And alcohol is used to do what? Help you sleep better? No, it's help.
Hydrophobic stuff.
Yeah, so it basically helps to any of the drug that doesn't really go into solution well into an aqueous solution. By adding that small amount of alcohol, you help to solubilize it and help to achieve that solution rather than having drug that's kind of insoluble and just sitting at the bottom that doesn't really get into solution all that well. So alcohol is used pretty commonly for that. Typically, if you had to imagine the palatability of those hydroalcoholic solutions, what do you think they taste as compared to, say, like a syrup? Yeah, kind of worse. Like, if you've ever done a shot, like, those, don't necessarily taste super great going down. They kind of burn. And so same thing, if you're dealing with a pediatric patient, it might be difficult to give them something that has a high enough alcohol content because they may, be really just unpalatable to them. So again, looking at oral solutions, typically you're going to see that they're easier to swallow. The nice thing about using oral solutions is they allow you to do flexible dosing. So if you have a patient who, say, a tablet size really isn't going to be small enough for them, or say you need to give a dose in between two different tablet sizes, oral solutions are really nice for that. So they allow you absolutely flexible dosing. They typically, you're going to see that they have lower chemical stability than solids do. So if you had a tablet versus a oral solution, you would see that usually the beyond use state is going to be less for that solution than the tablet, just because anything in a kind of an aqueous mixture is just inherently more chemically unstable. Also, having aqueous liquids are typically going to be media for microbial growth. That's why you'll see a lot of preservatives, a lot of adjuvants being put into the solution in order to help prevent bacteria from growing. And then you'll have plus or minus palatability. So some products will taste really good, some won't really taste any good. Me growing up as a kid, I thought old medicine tasted disgusting, but nowadays, especially working at the poison center, you'll have moms calling up saying, "Oh, my child drank the entire bottle of Tylenol because it's great flavor and it tastes great to them," right? So kind of plus and minuses to making drugs more palatable. Kids might be more likely to take it, but then they might be more likely to go seek it out and take all of it, which can be a problem. Some of the common excipients you'll see put into the products, including preservatives, things like benzoic acid, alcohol, parabens. There are possibilities for allergic reactions to some of these products. So just because someone says I have an allergy to this one drug product, make sure it's the actual drug and not one of the excipients that's in there as well. There could be dyes, there could be a problem, there could be other sweeteners or flavorants that could be interacting there. So again, always be suspicious of allergic reactions that don't really make sense, especially for drugs you don't see a lot of allergic reactions to in the first place. Some other types of liquids you might see being used. So solutions, again, solutions are almost always going to be used for intravenous use. Some of the considerations you have to look at include things like pH of the solution. So especially when you're looking at something like phenytoin, as I mentioned before, that drug has a really tough time going into solution. Again, that's why the oral product comes as a suspension, right? Because it's tough to get into solution. In order to get phenytoin into an IV solution, you have to increase the pH up to like 11, right? And imagine how good a pH solution of 11 feels in the veins. Not super great, right? Especially if you extravasate it and it starts to leak out into the tissue surrounding the veins, you end up having tissue necrosis that can occur. You can have this purple glove syndrome that can happen. It's a really, really big issue, especially from a medical legal standpoint, because it's so well known that you can have all the skin sloughing off due to this extravasation. So that's why it's really important that we have alternatives, things like phosphonetone, which is a more water-soluble version that goes in solution a lot easier, and you see less phlebitis with that. Obviously, sterility is going to be a big concern. Anytime you're injecting something intravenously, you want it to be a sterile product, which is why there's really tight regulations about the beyond use dates for intravenous products, how long something can be used for after it's been made, especially whether it's made in a sterile hood versus if you just draw it up at the bedside. Those change pretty significantly based on the kind of the conditions you're making them in, based on sterility concerns. You also have to consider solution compatibility. So say you order two different drugs to run at the same time. Well, patients obviously only have limited IV access. They may only have one or two lines available. And if you have to run multiple drugs at one time, compatibility can be a really big issue, right? So you may run into an issue where you say, well, I know my patient's getting this drug, and the nurse is like, well, I haven't been getting it because I haven't been able to get the ability to give that drug because there's other things that are continuously infusing. So compatibility is really important, and it's one of those things you can always ask a pharmacist to help with with, or look at drug references. Most hospitals will have a IV compatibility tool that you can use to look to make sure that, okay, well, I can give this norepinephrine continuous infusion with this antibiotic for my septic patient, right? And then also looking at things like tonicity, this kind of goes back to the pH. Obviously, you want things to be isotonic because otherwise they're going to be causing fluid shifts either into or outside of the vein, which can be painful. So we like to use isotonic solutions whenever possible, but sometimes you will see us using really hypertonic solutions for certain therapeutic indications. So one instance of that is, say, saline. So normal saline, does anyone know what percentage that normally comes in when I say normal saline? 0.9%, right? So 0.9% normal saline, basically that it turns out to be, and we'll cover this in a later lecture, but basically it turns out that there's 154 milliequivalents per liter of sodium and 154 milliequivalents per liter of chloride. And when you put that together, basically equals 308, and 308 is basically isotonic with the blood, right? Usually blood's anywhere between, like, say, 280 to 320, somewhere in that range. And so because it's an isotonic solution, you don't really see a whole lot of fluid shifts that can occur there. And in some cases, though, you need to give really hypertonic saline in order to cause certain physiologic effects. So sometimes we'll give really hypertonic 3% saline, which has a much higher number of milliequivalents per liter that we're giving in order to help draw fluid out of certain areas like the brain. So if you were to have a traumatic brain injury and you were having some cerebral edema occurring, you can give hypertonic saline to help draw that fluid out. So again, that's where we can use tonicity to our advantage in some situations. Moving on to ophthalmic solutions, basically the same principles kind of with the IV solutions kind of applied to ophthalmic products. Again, you want them to be sterile because again, you're kind of giving product to a kind of a not as well protected site as you would say like on a topical administration. So because of that, you want things to be sterile. You need to worry about things like the pH and the tonicity of it because otherwise it's going to be really, really irritating to the eye. So it's important to make sure that only ophthalmic products are going into the eye, which makes sense. But in some situations, you can look at areas like otic suspensions or solutions. You can actually get away with using ophthalmic products otically because of the fact that you're basically it's kind of it's just more skin. It's less sensitive. You can get away with using things that are maybe a different pH or a different tonicity and not really see a whole lot of irritation. So like in the cases of drug shortages, there's been cases where we're using ofloxacin ophthalmic solution. We're actually giving it in the ear for post-op tympanostomies and myringotomies that are being done to help prevent post-op infections from occurring. So that's one case where you can use ophthalmic and give it otically, but you can't go the other way around. Otherwise, it's going to cause a whole lot of irritation for the patient, right? Okay. And then obviously you have your capsules and tablets. Capsules are just going to be your gelatin shells that will have the liquid drug put inside of it. So you see like your Advil there. You see also the ones on the left are Tessalon pearls. It's benzonatate, it's an antitussive product. Those are really hard to manage because they end up spilling out and they just roll everywhere. And then you also have the capsules that can be basically two shells, kind of two halves of a shell put together. Essentially the bottom part of the shell is being packed with the drug and then you just put the top one on there. Again, those will dissolve as they get into the gastric contents and release the drug over a period of time. Usually these are a little bit more quickly releasing than you would see with something like a tablet for the most part. Usually you're going to be seeing more granules or powders being put into the kind of the two-shelled capsules versus the liquid-filled ones, right? And then obviously you have your tablets. These are going to be your kind of most standard oral therapy that we can administer. Nice thing here is this good convenient dosing. A lot of them are scored, so you can split them in half or in fourths, and if you need to give a lower dose than just what the base tablet is. Keep in mind though that based on the manufacturer and based on lots of different factors, the color, the size, everything can change with it, and a lot of the adjuvants that they use in there, the binders and fillers and things like that can change. And so you may have some people that respond really poorly to one brand of the product, but they respond well to another one. And then you may just say, well, maybe they don't really know the difference, but sometimes they do based on the dyes and things like that. So sometimes there's some credence to that. Okay, so any questions on the dosage form section before we move forward? Pretty straightforward. All right, now we're going to be talking about ocular pharmacology. So when you're administering medications to the eye, there's lots of different places you can administer it to. And so this picture, and I know it's probably freaking some of you out because it did me too, seeing needles go into eyes is not good. But basically here you can see a couple different areas where they can be administered. So obviously you can do it topically, where you administer either ointments or solutions directly to the eye itself. You can have subconjunctival injections of certain medications, and then you can also have retrobulbar and peribulbar injections as well. You can see the two, you can see where they're being injected at specifically. Obviously, subconjunctival is probably going to be a little bit more common than the other ones. You'll probably see these more being done kind of specialized ophthalmic settings. Again, obviously the most common one is going to be the topical administration of these medications. So like we said, topicals is going to be the most common. So looking at the absorption pattern of the different routes, obviously depending on the formulation of the drug, the absorption may change. So obviously solutions are going to be a little bit better absorbed than something like an ointment. The ointment is going to take time for the drug to kind of diffuse out of it in order to get to the eye, versus solutions, it's all right there basically. Obviously the utility of this one is going to be pretty convenient, it's more economical, and it's relatively safe. Patients can self-administer if they need to, or someone else can administer it for them. But it's the most convenient dosage form. Obviously, the limitations and precautions, you're going to see that obviously you can have some toxicity when administering, which we'll talk about when we get to the specific agents. You worry about compliance, because one thing you'll see kind of across the board with these ophthalmic products is that you have to administer them much more frequently than you do, say, like an oral product, right? Because the fact that due to the eye being able to wash away a lot of the drug pretty easily, you're going to be having to administer several times a day. So it's not uncommon to have to administer a drug 4-6 times a day. And again, how likely is your patient to be compliant with that? It depends, but less likely to be compliant than something I can just take by mouth 1 time a day, right? So again, compliance is going to be an issue here. You also worry about, and we'll talk about why this is in a second, you worry about systemic toxicity from medications being given to the eye due to the fact that you have that nasolacrimal drainage that can occur that leads to systemic absorption of the drugs. That can be a major site for toxicity that can occur in some cases with certain drugs. So that's some of the limitations for using the topical route. But again, far and away the most common one you're going to use. Looking at some of the other routes, obviously you're going to be seeing more kind of physical issues, especially if the injections are done improperly. But the kind of the pros of using some of these other things like the retrobulbar injections and intraocular is you can get the drug directly to the site of exactly where you need it to work, right? And so certain drugs may not be able to penetrate, say, the cornea all that well, in order to get to its site of action. So sometimes using these actual injections it will be therapeutically more effective than just giving something topically. But we'll focus mainly on the drugs that are going to be given topically here. I'll show you some examples of some other routes. So here you have a ganciclovir ophthalmic insert. And so you can see here where this device is actually inserted directly into the eye here, where basically it provides this, you see this kind of the cells here, this mesh where the drug has been implanted. And so ganciclovir is an antiviral agent, and the benefit of this is it can slowly leach out the drug over a period of time. So instead of having to administer something, say 6 times a day, you can just put this in with one surgery, and then it will release drug over a long period of time to hopefully supply a high local concentration of the drug and be therapeutically effective rather than having to get something systemically. Because obviously the problem with giving something systemically versus just topically to the eye is what?
It goes all through the body. It goes all through the body.
It goes all through the body, right? So you worry more about having a lot of systemic toxicities by giving something systemically than you do if you just apply it to the eye itself. So that's one of the major benefits of giving things topically in the eye is that you have the local effect right there, and you limit a lot of those systemic side effects. So other dosage forms you might see used, again, gels, ointments, solid inserts. Sometimes anything that is kind of a more semi-solid or solid dosage form is going to allow more time in the cul-de-sac. I mean, you're going to have more absorption. And even sometimes you'll have cases where the lacrimal duct will actually be plugged in order to help prevent a lot of the drainage of that. It's not something you see super common. Maybe you have cases like people like really severe dry eye, they can have some punctal plugs put in or cauterization of that. But essentially by doing that, you allow more time for the drug contact with the eye and this better absorption of it. And anytime you have an insert, an implant, doesn't matter where you put it, they're always going to be a controlled release, a long-acting dosage form. So you'll see sometimes, like with certain birth controls that are implants, you can see that those are long-acting formulations. You'll see some other ones as we go through the classes. Yes.
Does long-acting mean like months or even longer? Is it like weeks? Like what's the?
It depends. It depends on the drug dosage form. So I don't want to repeat the question just so that way it picks up on the other thing. So you ask, when you say long acting, what do I mean? Like, do I mean days, weeks, months, years? It depends on the dosage form. It depends on the drug. So say for instance, if you have certain, I go back to oral contraceptives because I'm a little bit more familiar with them than say ocular products. But say for instance, some of the implants, you can get away with using them for several months. Say 3 months up to a year. You guys know the copper implant that they have. They actually place it right next to the cervix that acts as a contraceptive. That one can be placed for 5 years. I can't remember the name of it off the top of my head. We'll talk about it when we get to that section, but certainly some of them can be placed for years at a time, right? It just depends on how much drug is actually being held within the product itself. Someone have the name?
Marina?
Yeah, Marina? Yeah, there you go. So anywho, so it can range pretty widely. Is there any other questions? Yes?
Do they come out?
Eventually they will come out. They probably have to go back in and...
Like, how?
They just yank it? No, I'm just kidding. Yeah, so when do these come out? Yeah, so it's probably another surgical procedure where you go in and would actually remove it itself. Obviously, some things may dissolve over time, but typically, like pharmaceutically implanted products, like they don't necessarily dissolve, so they would actually have to be removed eventually. From the eye. Put it in the eye, take it out of the eye. Yep. I mean, maybe you just leave it there forever. I'm not sure. I don't know. Anyway, so obviously this is not a super common thing that you would be seeing, especially in clinical practice. Like this would be for someone who is severely immunocompromised and is really at risk for cytomegalovirus infections. And we'll talk more about that in a little bit later. But again, not something super common. But yeah, I imagine you would have to take it out at some point. Okay, so looking at the ocular pharmacokinetics of these drugs, looking at the absorption, obviously the rate and the extent of the absorption are going to be dependent on several factors. First one's going to be the time in the cul-de-sac and the precorneal tear film. It's hard to say. But essentially, the longer the time the drug is going to stay in that cul-de-sac, the longer it's going to be able to be absorbed, the better absorption is going to be. Also, is going to depend on the nasolacrimal drainage. So the faster that's draining, so say you have like a lot of tear production, a lot of drainage that's occurring, you're more likely to see the drug be swept away from the eye and potentially be absorbed through the systemic into the systemic circulation. So we'll talk about some drugs tomorrow, I think, especially beta blockers used for glaucoma. When those get absorbed systemically, they can cause some pretty significant side effects due to that nasolacrimal drainage. Obviously, if drugs are binding to either tear or tissue proteins, that's going to allow them to stay around for longer and allow for better absorption. And then also, it's going to be important, especially depending on where the site the actual drug is working, for diffusion across the cornea and the conjunctiva. We'll talk more about that in a second, how that's being governed. Again, it can be affected by changing the drug formulation. So say, for instance, if you're comparing say an ocular ointment versus a solution, which one do you think you'd have to give more frequently? Solution, right? Because solution has less staying power, has less occlusivity, so it's able to be swept away a little bit easier. You'll typically see, and I'll show you some of the different dosages, dosing regimens, that you'll see that the ointments typically are given less frequently because of the fact that they stick around for longer. And like I said, blocking the tear ducts may help with help with the retention of the drug there for longer. There's no real clinical applications where you would block off the nasolacrimal duct just to give a medication, but just for instance, especially with people with severe dry eyes, they may have these done in anyway, and then you would see longer absorption of the drug in the eye. So again, looking at how the tears will actually be absorbed, once they are being produced, you can see how they will kind of travel through the eye and eventually get to the ciliary body into the systemic circulation. So that's really where you can see the majority of the drug absorption happening that can cause potential for systemic side effects. And it's not real frequent with the different drugs, but when we talk about specific ones, those are good ones to note. The other thing about having that nasolacrimal absorption is that it avoids first-pass metabolism. And you guys remember that first-pass metabolism is what? Yeah, right. So when a drug gets absorbed orally, it goes through the liver, and you pay your liver tax essentially, and that portion of that drug is going to get metabolized before it reaches systemic circulation. So here you're going to have a higher bioavailability for the drug that does make it to that point of absorption because it's bypassing the liver for its first time around the circulation. And again, that's where you're going to see a majority of your systemic side effects popping up from. Now, the transcorneal absorption, obviously this is going to be necessary for the local ocular effects. It has to be able to pass through the cornea to get to where it's needed. And so the amount of time that takes is called lag time. The time basically from administration to the time where the drug actually gets to the site of action is that lag time. And so lots of different things, bless you, can affect that. a lot of it's going to be dependent on Fick's law. You guys remember Fick's law?
Depth of the membrane or something like that.
Yeah, of course you do, right? Good thing I have a picture right here to remind you guys. So Fick's law is basically telling us the different parameters that are affecting aqueous diffusion across a membrane, right? So one, the bigger the concentration gradient, the bigger the flow we're going to have, the bigger the flux, right? So the bigger the concentration I have on the outside of the eye, the more flux I'm going to have go into this eye. The surface area is going to be important, so the bigger the surface area, the more absorption you can have. And then the thickness of the membrane is going to be really important here as well, right? So the thinner the membrane, again, the eye's pretty thin for the most part, it's able to cross relatively easily versus something like topical administration to the skin. It's a lot more thick. It's going to have a harder time absorbing, or at least be slower for the most part. And then you also look at the physiochemical properties of the drug itself. You look at things like the ionization of the drug and how well it's able to absorb. You guys remember the Henderson-Hasselbalch equation and all that? We talked about drug ionization. Remember, things that are in an uncharged state are able to cross those biological membranes much easier than something that's in a charged state, right? And again, when you're dealing with the ocular products, ophthalmic products, you're kind of limited in the pH ranges that you can have. So that may be affecting certain drugs and how well it's being absorbed due to its ionization state. As far as distribution goes, obviously you're going to see it occur normally after systemic absorption. So if a drug likes to partition itself out into the tissues pretty extensively, it's going to do that same thing here regardless once it gets absorbed. But you will see some drugs actually can accumulate in the eye itself. So if you look here after you receive chloroquine, which is kind of an old school anti-malarial drug, here's a picture of a bullseye lesion that can occur. And this is due to actual accumulation of the drug right there on the retina building up over a period of time. Right? So those are some unique examples there. As far as metabolism and excretion goes, obviously some drugs may be metabolized in the eye. There's some limited amount of enzymes that are available to do that, but for the most part, once the drugs get absorbed systemically, they'll go through in their normal metabolism, either through the liver, or if it's plasma esterases, or whatever it happens to be, and then renal elimination if that's where it's meant to be. You will see some drugs that will be administered as prodrugs. You guys remember what prodrugs are, right? What are they? Right, so they're inactive when they're given as the original form, and then they get enzymatically activated once they get to their site of action. So for instance here, you have the dipivefrin, which is metabolized over to epinephrine. Epinephrine, is a natural catecholamine, but for whatever reason, either due to chemical stability or whatever it happens to be, epinephrine cannot be administered itself. So we give a prodrug that's able to be absorbed and then get cleaved open into epinephrine where it can have its activity. You can also have latanoprost, which is going to be a prostaglandin analog that is used for glaucoma. We'll talk about next time. And that actually will get itself, again, the parent product has no activity itself, but once it gets changed into prostaglandin F2A, then it's able to have its activity as an anti-glaucoma drug. So next thing we'll get into, and we'll actually get into specific drugs now that we've talked about the actual kinetics for ophthalmically administered medications. We'll start to talk about some antimicrobials. We'll talk a little bit about it here in the ophthalmic sense, so we're only going to be talking about topical products. And then the third lecture is going to be like more extensive, like bugs and drugs. So we'll get more into systemic antimicrobials there. So this is where we're going to kind of focus on here. So again, infectious disease is going to be a super common complaint for people coming in. They're going to have a lot of conjunctivitis you're going to be seeing in order to treat. And you'll see that these periocular infections will kind of be separated out into either the preceptal or the postseptal / orbital cellulitis kind of realm. So the preceptal is going to be, say, more kind of I think more surface level. It's going to be easier to treat with topical antibiotics. Usually once you start to get into postseptal or orbital cellulitis, it's much more extensive, and at that point just using a topical ophthalmic product isn't really going to be useful enough, right? Because it's not going to be able to get to all those tissues that are infected. And so in those cases you typically need systemic antibiotics in order to help treat those. And so we'll talk about those in a couple lectures. So we'll be focusing mainly on the preceptal conjunctivitis when we talk about these antibiotics and their use. Again, the route, whether you're going to use more topical or systemic antibiotics, is going to depend on lots of different things. So the clinical setting. So is there some kind of preceding trauma? Is the reason why you're treating with antibiotics? So say there was some accident where there's some kind of puncture that could occur that may lead you to use one route versus another. Looking at age, obviously extremes of age. If you have an infection in the eye, you may be more likely to spread. If you're at the ends of the age spectrum, certainly if you're in an immunocompromised state, that is going to predispose you to more severe infections. So things like cancer, especially the neutropenic, HIV, etc. And then also just the involvement of the disease itself. So when the time they come to you, how much is kind of extended into the surrounding tissues will lead you to think to treat more systemically versus just topically. So looking at the kind of the spectrum of bacteria that we're going to be treating, it changes over time. So if you look at things like Haemophilus influenza, after the vaccine is introduced, you start to see big decreases in the rates of infection by that bug mainly. So again, things will change over time, but in general, what you're going to be seeing is that when we're treating topically these ophthalmic products, we're going to be using pretty broad spectrum antibiotics. And when I say broad spectrum, what does that mean to you guys? Yeah, it kills all kinds of bugs. So instead of just saying, you know, I have an antibiotic that can treat one type of bacteria, I'm going to give you an antibiotic that can treat all types of bacteria. And what are some of the inherent problems with using broad spectrum antibiotics? Resistance is one of the biggest ones, right? So you worry about if I give a broad spectrum antibiotic, I can put selective pressure to have more resistant bacteria come back, and all of a sudden my drug doesn't really work anymore. The difference here with using these topical products, I can get away with using broad spectrum antibiotics is one, the concentration of the drug that I'm administering is so high that you're basically eradicating everything, right? So the other advantage of administering something topically to the local site of action is that you can get away with using much higher concentrations of the drug than you would see if you were to get it systemically, right? So that way you're able to basically eradicate those bugs. You don't really have to worry about resistance really popping up. And traditionally, you don't really see a ton of resistance happening here. We'll talk about some examples where that does happen though. And then the other kind of downside of that is that you're going to require more frequent dosing, though, because of the fact that just by nature of it being an ophthalmic product, you do have to dose it more frequently. Typically, you're not going to really see a whole lot of cultures being done. So normally, if you have, say, you're treating a pneumonia, you want to get a culture to see what the causative bug is. But in these cases, you usually don't have to worry about it because usually the broad spectrum antibiotics you're going to get are going to cover the bacteria you think it is. The only exception to that would be if it's like an immunocompromised patient. You're worried about specific type of pathogen that your antibiotics are not covering for specifically. So say, for instance, you're worried about a pseudomonal infection. Not every single topical ophthalmic antibiotic is going to be able to treat Pseudomonas, and so you might need to culture that out to see if it's actually there or not, right? So looking at conjunctivitis, obviously you're going to be, the things you're going to be seeing are this mild hyperemia, you have this purulent discharge. The most common causes, obviously you're going to be viruses, right? You have viruses, you have your allergies, environmental irritants, and then also contact lenses can be another cause for this. So do antibiotics work for any of these? Nope. Probably not, right? Do we probably still treat most of this conjunctivitis? Depends on the situation. Less common causes would be, immune-mediated reactions. Sometimes systemic diseases or tumors could potentially be causing this conjunctivitis. If you were to look at which infectious pathogens are most common, you would certainly see things like Neisseria, Haemophilus, which is kind of in decline, strep pneumo, and then potentially even staph, right? So things that are growing on the skin may be potentials for causing infection here. The main goal when we're treating with this is going to be to eradicate the infection and then to prevent any kind of long-term complications, either changes in visual acuity, blindness, things like that from occurring. So before I let you go on break, I'm going to leave you with this slide. Just memorize everything on this and you'll be fine. Just kidding, don't do that. The main thing here is to note, we're just going to focus on conjunctivitis. So even though there'll be ones with specific indications for, say, we'll focus on some of the ones that are more specific when we get to individual drugs, but don't worry about the indications for use, and don't worry necessarily about the formulation. Just realize that the concentrations that are being used here, again, those are concentrations that are applied topically and locally to get really high concentrations of the drug in order to help kill off those bacteria. Notice some of them will have, most of them are solutions, but you will see some that are ointments that are available. We'll talk about some of the benefits of those when we get to them, especially when dealing with certain patient populations. But these are the main antibiotics that we're going to be talking about for this section. So again, I'll let you guys go for a 10-minute break, and we'll come back and finish this up. So one question that came up on the last slide, all the antibiotics. So again, yes, those are all antibiotics that could come up for testing purposes. I list all the brand names there again, but I only would say memorize the generic names. Some people just do better when they have brand names available, as far as like being able to recognize the drug and placing it to a category. So just keep that in mind, but the generic names, certainly I would definitely memorize those. Okay. Any questions from the first section of the class? Good thing that came up. So in regards to solutions and for IV administration, so someone's like, well, there's this one drug I used to mix up all the time. It just took forever to go into solution. So has anyone ever mixed up a drug that was freeze dried, right? It came as a powder in a vial. So those drugs have to be reconstituted before they can be administered, right? So you have to inject either saline or sterile water into the vial, and then they'll go into solution. Some drugs take forever to go into solution, right? Some of them will have to sit there and you have to shake them like crazy. Some of them, they're protein-based and you can't shake because otherwise they'll denature and then they're going to be no good. So you have to sit there and just kind of roll them between your fingers for a while and let them go into solution. So those are still solutions because the drugs are completely dissolved throughout. Even if you left it there for a while, the drug would still be there, would not actually settle out. It's just that dissolution process can take a while depending on the drug properties itself. So, and even if something seems really thick when you're administering it, that's still going to be a solution that you're administering. So anything IV needs to be a solution. We'll talk about some examples in the antibiotic section where you can actually give a suspension, but it can only be given intramuscularly. Otherwise, you run that risk of causing embolism, right? Okay, moving on, the first section of antibiotics we'll talk about for ophthalmic use are going to be our macrolides. So the most common one you're going to be seeing used here is going to be erythromycin ointment, and then you'll also see azithromycin solution being used as well. So again, main indication here for the ophthalmic use is going to be for conjunctivitis. And the way that these are going to work in order to help inhibit the bacterial growth is by working on the 50S ribosome. So essentially what happens when you have translation of the bacterial DNA, it's going to come in order to get transcribed to produce new proteins. And so by working at the 50S ribosome, by blocking that translation from happening, essentially you prevent these new proteins from being produced, and thus the bacteria is not able to continue on its normal cell processes and eventually will die out. Right, especially in conjunction with your body's normal immune system kind of coming in to help out as well. We'll talk about other drugs that affect other ribosome subunits. I'm not going to get so granular as to say, well, in a test question, like, does this one affect the 50S or the 30S? I don't think clinically that's super useful for you guys to know. I do expect you to know that it affects protein synthesis by affecting the ribosomes, and that's how it's going to be causing its antibacterial effect. Because when we talk about different antibiotics and maybe using different ones at the same time, it's important to realize which ones have what mechanism of action, which ones make sense to combine, right? So I wouldn't want to have necessarily two drugs that are affecting protein synthesis. Maybe I want to have one that affects the cell wall and then one that affects protein synthesis because they'll work synergistically together instead of kind of covering each other and doing the same thing, right? So again, don't worry so much about which ribosome subunit it is, just know that it affects the protein synthesis by affecting the ribosomes. So by doing that, it's going to kill off the bacteria eventually. And just note that the main adverse reactions you're going to see are going to be eye irritation and also this hypersensitivity that can occur pretty rarely, though. But for the most part, it's well tolerated. And no real drug interactions to speak of. And you'll see that's pretty common for the ophthalmic products because, again, it's hard to have drug interactions when they're really only working locally and not really getting into the systemic system, right? As far as looking at the differences in the dosing regimens, and again, I'm not going to ask you specifically how to dose this drug, right? You guys are going to figure that out in your clinical practice, on your rotations. I only point out the dosage regimens in regards to illustrating certain points, either with the kinetics of the drug or something about the formulation. So again, just because it says 1 gram Q12, don't memorize that stuff because I'm not going to test you on that necessarily. I may test you on concepts about why you would dose a drug Q12 versus Q24, but just keep in mind that I'm not going to ask you specifically how to dose this drug. Okay, I know it's a big worry for a lot of people. So looking at the differences between the two macrolide antibiotics you can use ophthalmically, if you look at erythromycin, it comes as an ointment. And so that one you're actually going to be dosing it in inches. So in this one you say apply half an inch 2 to 6 times per day depending on the severity of the infection. So again, obviously the more severe it is, probably the more frequently you want to be giving it. So you may need to give it up to 6 times a day or every 4 hours. At least while the patient's awake. And again, half an inch with these drugs, it's kind of it's not rocket science. So again, if it's a little bit more than half an inch, a little less, probably not going to make a big difference, right? As long as you're getting roughly close to half an inch on the eye and letting it stay there. Now, this dosage form, being an ointment, is a lot better for pediatric patients, especially because how hard is it to give an ophthalmic drop to a peds patient? ever tried to wrangle, like I have a 3-month-old at home, and she's already hard enough to like do anything with, right? She's all squirming around and what. So it's hard to give drops to kids, right? So at least by giving the ointment, even if you can only like get it on their eyelashes, you know, at least as long as you're close and it's still making some contact, it can still be effective, right? And because it's an ointment, it has better staying power than a solution would, and thus it can potentially be more efficacious for that age group. The azithromycin, being in a solution, this one you're going to be giving this one they can actually give less frequently, so this one can be given just twice daily. So that's actually pretty unique for the solutions here to give it this infrequently. Usually you're going to be giving a lot of these drops either 4 or 6 times a day, as you'll see as we move forward. This probably has a lot to do with the azithromycin having a longer half-life. You guys remember half-life is what? Yeah, the time it takes for half the drug to be metabolized. So, you know, for whatever reason, you know, azithromycin has a longer half-life than some other antibiotics, and so it has better staying power in this case. And so this one you dose just you know, twice daily for up to 5 days.
How long do you administer the azithromycin?
It depends on the infection. Usually, you know, it can depend anywhere between 7 to 10 days, probably more commonly. But again, if it's more severe infection, if it's not getting better, that may be a case where you either need to treat for longer or need to come in and see if there's something else going on. Yep. Actually, I can't go back. But one other thing to note with the azithromycin, notice how it was said to give 2 drops on the first day and then give 1 drop on the subsequent days. You'll see that's pretty frequent with the azithromycin, where you're giving a bigger dose on the first day and then you're giving half the dose after that. And what is that an example of? What kind of dose is that?
Loading dose.
A loading dose, right? What does a loading dose do for us?
Gives us spike.
Yeah, basically it's going to get us to our
Therapeutic index.
not therapeutic index. It's that state at which we're steady state, right? So basically, even the loading dose kind of bumps you up to your steady state, so that way you're not having to give those give those individual doses to kind of build you gradually up to steady state. Because again, how long does it take to get to steady state normally?
4 to 5 half-lives.
Yeah, 4 to 5 half-lives. So depending on the half-life of the drug, that could take a while. And so in this case, with azithromycin, we can give a big loading dose up front, get you up to steady state, and then you're doing subsequent smaller doses as your maintenance doses to maintain that steady state. So erythromycin itself is pretty soothing on the inflamed eye because, again, it has good staying power. It's that ointment. So again, even if you don't have a bacterial infection confirmed, and again, a lot of time you see adenoviruses and things like that being the causative organism for this conjunctivitis, it's really not going to be a big deal if you give it to someone who has a virus administered, because again, you're not really all that worried about resistance developing in these kind of topically administered medications. Azithromycin, though, on the other hand, is considerably more expensive, although it is nice that it's given less frequently, but you oftentimes will not see it used all that frequently clinically when the erythromycin is just as effective and much less expensive. They may see it in some unique circumstances where, say, they can't tolerate it or they're not going to be compliant with more frequent dosing. That might be a better option for them. Moving on, we'll have our polytrim solution. So this is a combination product. We actually have trimethoprim and polymyxin B. And so this is a case where we're using 2 different antibiotics with 2 different mechanisms of action to have some synergy here. So for the trimethoprim, the way this is going to work is actually by inhibiting the reduction of folic acid to tetrahydrofolate. And so if you can't really process folic acid within the bacteria, it's not going to be able to commence with cell replication because it can't produces DNA appropriately. And so that's eventually going to lead to cell death. On the other hand, polymyxin B takes a little bit more direct approach, and so basically what it can do is bind to these phospholipids on the outer membrane of the bacteria and actually kind of puncture through it in order to release the cytoplasmic materials out, and that causes kind of direct cell death. And normally polymyxin B, you don't really see it being given intravenously all that too often because the nice thing about antibiotics is that they're very selective for bacteria, right? Because you don't want them to be selective for human cells, because otherwise they'd start to kill off those cells, right? That's where we get chemotherapeutics from, right? So polymyxin B, even though it's relatively toxic when given systemically, lots of issues with renal toxicity, ototoxicity. Now, at least when given it topically, you don't see that systemic absorption. You see a lot less systemic side effects from that. So that's where we can get away with using it topically and in the eye as well. So again, here you'll be giving every 3 hours for 7 to 10 days. Some people will say you can give it a little bit more frequently. And use it for a little bit shorter period of time. And again, bacterial conjunctivitis is the main indication we're going to be seeing used here. And again, adverse effects, really ocular irritations, the biggest thing. Unlikely to see a whole lot of allergies to this, and then no clinically relevant drug interactions to pop up here. We then have sulfacetamide, and so this is a good picture that also refers back to that trimethoprim we just talked about. Sulfacetamide works against folic acid in the bacterial cell. It just works at a different step in the production of it. So you can see here that the sulfonamides are kind of the class of those drugs. So again, sulfamethoxazole is going to be another big one we see that falls in this category when we talk about Bactrim. You guys have heard of Bactrim before? Yep, it's a very common antibiotic used for things like UTIs and skin and soft tissue infections, but the sulfonamide that's included with that is called sulfamethoxazole. And so anyway, sulfacetamide, sulfamethoxazole, they both work by inhibiting this PABA, this para-aminobenzoic acid. And so essentially by blocking that conversion over, you're preventing the dihydrofolic acid from being made, and then you see your trimethoprim working, preventing the tetrahydrofolic acid from being made. So by working on the two different steps of that process, you're kind of having some synergy there. In this case, though, you're just giving sulfacetamide by itself. We'll talk about the combination of trimethoprim with a sulfonamide when we get to the other antibiotic section. But sulfacetamide is a sulfonamide working against PABA, para-aminobenzoic acid. Again, this one either comes as a solution or an ointment. So, depending on your patient, the ointment may be a better fit for them. The other thing you're going to see here is that you're more likely to have allergic reactions. So if your patient has a sulfonamide allergy, you wouldn't want to administer this. So a lot of people say, oh, I have a sulfa allergy. What you end up seeing is that just because a drug has sulfa in the name doesn't mean that it actually has the sulfonamide actual chemical moiety to it. So the thing is to be specific and say the sulfonamide allergy. If you have that, then you wouldn't want to administer this drug because they're more likely to have a reaction to it, right? So it makes the conjunctivitis even worse in those situations. Does that kind of make sense? Clear as mud? All right. Moving on, then we have bacitracin. So this one is another drug that you see frequently used topically, but again, due to potential for systemic toxicity, you never see it used parenterally for the most part. So again, bacitracin will work by inhibiting the bacterial cell wall synthesis. You'll see this is a very common method for causing bacterial cell death by preventing the cell wall from actually being made. And so this will be basically prevents the propagation of the cell wall from being made, leading to cell rupture and cell death. Can be used for bacterial conjunctivitis. Irritations are the biggest thing you're going to see here, and this one can be applied because it comes as an ointment less frequently than you see with some of the solutions. And again, no significant drug interactions. Try to use ophthalmic stuff as a kind of a starting point for you guys, kind of easy into it, because once we get into the systemic drugs, it's going to be a lot worse. I mean, better. It's going to be a lot better. Moving on, we then have another class called the fluoroquinolones. I'm sure you guys have heard of some of these. The agents that will be included with this, there's lots of different ones, but includes things like ciprofloxacin, ofloxacin, levofloxacin, moxifloxacin, and gadifloxacin. So obviously you can tell a fluoroquinolone based on the name, right? So it ends with the oxacin, probably is going to be a fluoroquinolone. Can any of you identify which two drugs in these in this group are chemically related?
Cipro and Levo.
Cipro and Levo, I think that, potentially. It's actually going to be the ofloxacin and the levofloxacin. So, I think we talked about in pharmacodynamics, but essentially ofloxacin comes as a racemic mixture, right? You have the left and the right-sided hands of the molecule, right? You guys remember chirality and all that? I don't see any shaking heads, but I'm assuming you remember chirality. Anywho, one thing that you can do to make a brand new drug is to just take one of those sided molecules and make it into a new product. So anytime you see levo in front of a drug name, typically that means it's going to be the left-handed version of that drug. So say, for instance, you have albuterol, which is used as a beta-2 agonist for asthma. If you were to take the left-handed version of that, you have levalbuterol. Now you have a brand new drug. You have a brand new patent. You start to sell that. And so they say, in a lot of cases, you're trying to just use the one enantiomer that has the physiologic activity that you're looking for. And sometimes you can actually eliminate a lot of the side effects that you don't want to have from the other molecule. That may not always kind of bear out in the clinical setting, but that's essentially what they're doing it for, is to try to get something that's a little bit more pure, that just has the therapeutic effects you're looking for without the toxicities. So in this case, they have ofloxacin. If you take the left-handed version, you have levofloxacin. So those two are chemically related to one another. These are going to work. Again, another mechanism of action we see here is actually works on the DNA itself by inhibiting two different enzymes. And so you'll see DNA gyrase and this topoisomerase 4. So by inhibiting the bacterial specific ones, what we can end up seeing is you have these enzymes that are responsible for kind of relaxing the superhelical structure of the DNA and responsible for some of the strand breaks that occur in order to help kind of open it up and allow for the translation to, or the transcription to occur. And so by inhibiting that, you prevent the DNA from kind of unwinding itself, and thus you cause more strain breaks to occur and end up leading to eventual cell death. Because again, once the cell realizes that all this DNA is kind of no good, it can induce apoptosis, and then you can have cell death that can occur. So I'll show you a picture of that in just a second. Big thing here is that these drugs are going to be limited in use. You don't really want to jump to these guys as your first line therapy unless it's for specific reasons. The indications obviously are going to be for conjunctivitis, but these are also going to be useful for corneal ulcers. Okay, so that's kind of a specific indication might be worth noting. Some of the things that you can see as side effects with this one, again, ocular irritation. With ciprofloxacin, some of the fairly common ones, I think it's mainly just due to the drug. When the solution dries out and you're left with some of this white precipitate that can be left on the eye itself. It's not dangerous, but it can be something that's a little bit troubling to your patients. It's definitely a good thing to let them know about so they don't think that they're getting worse. They have all this white flecks on their eye. And then you can also end up seeing some of this unpleasant taste after installation. So that's not an uncommon thing to see, especially due to that nasolacrimal drainage, because again, you're going to eventually end up tasting some of that as it goes through, right? And again, fortunately, there's no drug interactions they're going to be worried about with the fluoroquinolones. So looking at the mechanism here, you can see both the GNA gyrase and the topoisomerase 4, which are usually used to kind of loosen up the DNA so it can kind of open up and be read. But by preventing that, you see more DNA strain breaks and eventual cell death. So for the most part, these drugs are effective, they're well tolerated. The bonus that these drugs have as far as coverage goes is they actually can treat Pseudomonas aeruginosa. So Pseudomonas, as you'll learn, I'm sure in microbio and all kinds of other classes, that Pseudomonas is a pretty nasty bacteria, right? You typically don't see it unless there is kind of an inciting reason for it. So in a lot of cases, either the patient's immunocompromised. In some cases, it could be due to things like foreign body. So especially patients with contacts, they may be more likely to have Pseudomonas infections just due to having that foreign body there. It can eventually accumulate kind of gunk and eventually get the bug there. Other problems with the drug is that they are typically, in general, more expensive than a lot of our older agents. Things like bacitracin, things like your polytrims, they've been around for decades, and so they're fairly cheap. Whereas these guys are typically a little bit more expensive since they're, on the grand scheme of things, a little bit newer. You also worry about emerging resistance. So certainly you can see with overuse resistance to these drugs developing over time. And so you see this especially more on the oral side for outpatient treatment of things like upper respiratory infections or lower respiratory infections. You see a lot of resistance starting to develop to these. And so it can be a huge problem because they're really good drugs, but everything's resistant to it, then they're useless. The dosing is going to be kind of dependent on the indication you have, but can be very frequently. Typically, you're going to start a little bit more frequently in the first couple of days and then kind of scale back therapy as you move along. And again, for conjunctivitis and contact lens wearer, once you kind of rule out keratitis as being there, this is going to be your go-to drug because of that high risk for Pseudomonas, right? So it's probably a good thing to remember in case there's any kind of testing that were to come up ever. Yeah, what? Huh?
Why can't you give it if it's... Would you give something else if it's keratitis?
Yeah, so if you were to see keratitis, you might be giving something else. You might be using steroids or something like that, depending on the indication. But yeah, once you roll that out, once you say, okay, well, I'm pretty sure this is bacterial conjunctivitis, and I'm pretty sure, because they're a contact lens wearer, I think that this is more likely to be Pseudomonas. This is why you would jump to these drugs versus using something like a polytrim or erythromycin as your first line drug.
This is a solution or not?
Most of these come in solutions. You can refer back to that first. For that one slide with all the antibiotics on, you'll see what's on there. Yep. Okay, we also have some aminoglycosides as well. So we have gentamicin and tobramycin. You'll see there's a third aminoglycoside that's not used as an ophthalmic product, but used systemically. This one is going to be interfering with bacterial protein synthesis. It's working on both the 30S and the 50S ribosomal subunits. And again, that's preventing protein synthesis from occurring. So kind of similar to macrolides, but this one's working on both the 50S and the 30S ribosome at the same time. Again, main indication is going to be conjunctivitis. This one you can see ocular irritation and corneal ulceration developing. So the stuff, you don't see it used all that too often because it can be pretty irritating to the eye. Again, you can see this reactive keratoconjunctivitis that occurs after several days of use. So you really don't see it used all that too often. Mainly because of the fact that it has pseudomonal coverage, the aminoglycosides, you might be seeing it used for that a little more frequently. Right. The other thing you'll see with the aminoglycosides is that gentamicin is typically the antibiotic you see being put on a neonate's eyes right after birth, because again, it's going to help to prevent any infections from going through the birth canal that might have picked up along the way. Right. So gentamicin will get like a one-time dose of that slathered on, and then you're kind of done because you don't have to worry about delayed infection from that standpoint. So anyway, you'll see pictures like this all over the place that talk about where the different antibiotics will be working at. Again, we'll talk a lot more about these later on this week when we get to the antibiotic section. Probably enough that you'll probably want to go jump out the window by the end of it. But anywho, but just be aware that the mechanism of action of different antibiotics are going to be really important to keep straight. So know which ones are going to be working on your bacterial cell walls, know which one are going to be working on protein synthesis, know which ones work on DNA gyre, all things like that. Keeping mechanisms straight are going to be really important from that standpoint. Okay, moving on, we'll talk about some antivirals we can see being used in the ophthalmic realm. So again, primary uses you're going to see are going to include viral keratitis, herpes zoster, ophthalmicus, and also retinitis. Unfortunately, we cannot use antiviral ophthalmic products for these conjunctivitis caused by adenoviruses, because that's going to be your most common cause for conjunctivitis, or one of the most common causes. Unfortunately, none of the ones that we have are really going to be effective for adenovirus, right? So these are the specific instances where you'd be using antivirals. And again, these are not going to be your run-of-the-mill patients. These are going to be patients who are coming in, they're probably more likely to have concomitant disease states and make them more immunocompromised. Because normal, healthy individuals usually don't get viral infections in the eyes from these type of bugs. Usually you need to have some immunocompromisation occurring that makes you predisposed to it, right? So the ones you'll see in this table, the ones I highlighted are the ones to focus on. So the trifluridine and also the ganciclovir. The other agents you're going to see are all going to be oral products. And we'll talk about the oral or intravenous products. So we'll talk about it at a later time. I just put these on here to show that in a lot of cases, using ophthalmic products may not be enough for these particular instances. You may need systemic therapy in order to help treat them. So especially for those immunocompromised patients who may have more involved disease, the systemic products are going to be probably preferentially preferred for them. But these two are the ones from the topical section that we'll focus on here. And we'll talk about other antivirals later. So again, trifluridine comes as a topical solution, and we have that ganciclovir, that's that vitrocert that we saw previously, where they actually insert it into the globe itself. And just know the different indications for these two. So know that the ganciclovir is really going to be for CMV, a cytomegalovirus retinitis, and then the trifluridine is going to be better for the herpes based viruses. Yes.
Do you see the difference between the highlighted and non-highlighted? Is non-highlighted mostly the oral administration?
Yeah, so the non-highlighted are either going to be oral or parenteral therapy, but since I'm only focusing on the ophthalmic products, these would be the only two that would be like up for testing purposes from this section, right? Mm-hmm. Okay, so trifluridine or Viroptic, this one works, and you'll see a lot of these antivirals work kind of similarly. They may change up the specifics a little bit, but basically they're working by blocking viral DNA replication. And so in this case, you'll see that trifluridine is actually going to interfere by inhibiting this thymidylate synthase and incorporates it into the viral DNA in place of thymidine. So by kind of masquerading itself and getting placed into the DNA, instead of thymidine, when the proteins come along to help replicate the DNA, they're going to get to the stopping point. They go, what is this? They don't like it. They try to get rid of it, and so eventually that's going to lead to cell or the viral death when it triggers that. So by blocking the DNA synthesis, you prevent further viral replication, right? In this case, trifluridine would be specifically used to treat herpes simplex viruses. So again, if you had a test question that came up and said, patient with cytomegalovirus, retinitis, which one of these would be appropriate to treat with, this would not be the answer, right? Adverse effects include this ocular irritation and then also this punctate keratopathy that can occur as well. So you kind of see that maybe with more chronic use, you can see those build up under the Woods lamp. And then no specific drug interactions we'll talk about here. Next we have ganciclovir. This is going to work very similar to the trifluridine, but in here you're going to see it kind of go in the place of guanosine. So it'll get incorporated into the viral DNA and prevent replication by blocking the replication of it. This one's going to be better for cytomegalovirus cytomegalovirus retinitis, but that's specifically that intravitreal insert. So you may be doing like systemic therapy on top of doing the insert as well to make sure you're treating the patient kind of holistically due to the fact that they're immunocompromised and more likely to have a more involved disease. And then again, no drug interactions here. I'll show you the mechanism of action in this picture here. You can see how it gets incorporated. And again, this is similar to a lot of the other antiviral products where the ganciclovir, that GCV, ends up getting phosphorylated. So you see you get phosphorylated a couple times, it gets over to the triphosphate form, and then that's where it gets incorporated into the viral DNA. And then that DNA polymerase, once it encounters that, it can't go any further, it doesn't like it, and will eventually lead to the viral death. Okay, as far as ocular antifungals go, there's not many. We have natamycin. This is actually the only one that's commercially available. So again, this is going to be a big concern for immunocompromised patients. Obviously, they're going to be more at risk for having these fungal infections that'll pop up. Obviously, other things that put you at risk for developing an ophthalmic fungal infection are going to include trauma. So if you were to have someone have some kind of penetrating injury, something like that, we're getting like a lot of things from the ground being exposed to the eye. If you have any kind of chronic ocular surface disease, contact lens wear may predispose you, and then obviously the immunosuppression. That can even include if you're using topical steroid use. We'll see in the next section where you can use topical steroids to treat certain ocular indications, and that can even lead to kind of a local immunocompromisation that can make you more likely to have a fungal infection. So something to keep in mind. Again, the list here mainly is going to include things that are either oral or intravenous. The amphotericin B can be compounded, but it's not commercially available as an ocular product. You can see here you can do subconjunctival injections or intravitreal injections. I'm not going to focus on that so much because we'll talk about amphotericin B at a later date, because you'll typically see it being used more intravenously than anything. But again, natamycin is the only one that's topically is commercially available that you can purchase from a pharmacy. Otherwise, you would be treating it with either oral or intravenous antifungals, so things like fluconazole, itraconazole. We'll talk more about those later as well. Again, natamycin, it works by increasing the cell membrane permeability in the fungi. So I'll show you some pictures when we get to talking about the antifungals, but their cell walls are obviously made a lot differently than the bacteria or a mammalian cell. But basically the natamycin itself, because it's targeting the fungal cell wall specifically, it's not causing a lot of other systemic effects on our normal cells. But it's able to increase that permeability and allow for the cell contents to leak out and eventually lead to the fungal death. Again, it's used for conjunctivitis or keratitis, and it's pretty wide spectrum, so it's able to treat things like Aspergillus, Candida, Fusarium, Penicillium. All these different causative organisms are usually going to be covered by the natamycin. Again, ocular irritation is the biggest thing you're worried about there, and no drug interactions to speak of. Okay. So whenever you have a patient who is presenting with eye complaints, again, prior to instilling any medications, you want to make sure to perform a visual acuity beforehand. Why do you think that's important?
Before and after.
Right, you want to see whether there's any changes. So especially if things are getting worse, it's obviously going to be pretty concerning to you, right? Or if things are getting better, that's going to be a good sign. Obviously, you want to look for any allergies to medications. So what are some main allergies you would think of just off the medications we talked about? So yeah, sulfa I heard about, so again, if they have a sulfa allergy, that would lead you to not want to give which drug? You guys don't remember them already? Jeez. No, it's that sulfacetamide, right? So the polytrim, the sulfacetamide and polymyxin B, they had a sulfonamide allergy, you would know, okay, I probably don't want to give this drug. Maybe I need to go with something else, right? So document any allergies they might have beforehand. And then any other, eye exam results that they've had previously. And again, when you do the follow-up, then again, you want to document your visual acuity again to look for any changes, either better or worse. Again, obviously, if it's getting worse, that's when you need to consult ophthalmology because there could be something else going on that simple ocular topical products are not really going to be cut out for. Next question is, how do I administer an ophthalmic medication? So first thing you have to do, because again, a lot of people may skip these steps. This is really good patient information that you want to make sure they're getting prior to trying to instill these on their own. So again, most important step, wash your hands. Just do it. A lot of people don't think about doing this beforehand, but again, this product, if you get a bottle of an ophthalmic medication, you need to keep it sterile from use to use. And so the best way you can start out with that is by washing your hands beforehand. Again, avoid touching the dropper to anything, because again, that could lead to contamination of it. And then you want to make sure they tilt the head back and pull down the lower eyelid to make sure they form that pocket there. And then hold the dropper with the other hand without touching the eye, but getting as close as they can in order to drop it into the pocket there. Okay, anyone know what the next steps are without looking?
Keep your eyes closed.
Keep your eyes closed. Anything else you want to do?
Look around.
I saw someone doing it. Why do you do this?
Block the pump.
Yeah, right. So it's going to block that nasolacrimal drainage. So by doing that, by closing the eye, kind of tilting forward and closing off that nasolacrimal drainage, you help to increase that time in the cul-de-sac in order to allow the drug to be absorbed a little bit better. Again, you don't want to do that with a dirty finger, so again, wash your hands beforehand. And then you can hold the eyes closed for 2 to 3 minutes or so. If you're administering multiple drops, so you have different medications, say you have a glaucoma patient who's on a couple different ones, can you give them one right after the other? Probably not, right? Because again, you could end up washing one away before it really has a chance to be effective. So usually you're going to separate out some time, say 5 to 10 minutes or so, to allow the drug to be absorbed before giving it. Again, you'll see when we get to the glaucoma section that a lot of those products come as combination products. And so in order to decrease the number of drops that they're having to give, you can put 2 drugs in one and kind of eliminate that worry there. But again, once you're done with the absorption after 2 to 3 minutes, wipe off any excess and then wash your hands again. And hopefully you'll keep everything sterile. And so, if you're starting out with, say, just a regular, viral conjunctivitis, don't give yourself, a bacterial one. So keep your hands clean. Again, looking at our dosage forms, we talked a little bit about this already, but drops versus the ointments. Obviously, ointments tend to be a little bit better for the kids. Especially because they are a little bit more tough, and so poor compliance is more likely. And even if the drug's on the eyelashes, you can still it can still make contact with the eye, so it can still be effective. Again, with ointments, you typically are going to see blurred vision with those, and that may take 20 minutes or so to clear up. So especially if you're doing it to both eyes, you don't want to drive or tell them not to drive until the vision's totally cleared up for that. As far as gels and ointments go when you're applying them, it's a pretty similar process. The only difference is that you're going to be squeezing a ribbon of medication onto the eye, and you don't really need to hold the lacrimal duct closed because it has better staying power than ointment does, so you don't really need to worry about that. So as a bonus thing, does anyone know what to do if someone were to glue their eye shut with super glue? Has anyone done this on accident? That's good. How could you potentially get their eye back open? Just yank it? No, you can actually use erythromycin ointment. So erythromycin ointment is really good because you can actually apply it, and it allows the kind of the oil-based properties of it, because it's in a gel or in an ointment. It allows it to dissolve the super glue, the cyanoacrylate. So that can, you put it on there, leave it on for several minutes, and eventually the eye will just kind of come open on its own. Because usually the eyelashes end up getting glued to the skin around. But yeah, that'll help to clear that up. There's several kids in the peds ER. They'll come in with their eyes glued shut, and of course they're freaking out, mom's freaking out, but it's really a simple solution. Just do some erythromycin ointment and they're good to go, right?
What happens to the eye? Nothing happens to your vision? Nothing happens to
Typically no, because usually they're not getting it directly in the eye, but the stuff is really non-toxic for the most part. And the eye itself doesn't really get glued to anything. It's usually the lid getting glued to, either the eyelashes getting glued to the skin surrounding.
What about people who use something that's not an eye drop instead, like they glue directly into the eye?
I've not seen any problems with that specifically. Again, like I said, cyanoacrylate itself doesn't really cause any interactions. You may consider doing like a good Woods lamp exam where you do the fluorescein just to look for any corneal abrasions. But other than that, they're usually pretty good to go. Yeah, you usually don't worry about any kind of long-term visual acuity issues or anything like that. Okay, as far as contact lenses go, patients with contact lenses and conjunctivitis should discontinue use. So tell them to wear their glasses. Maybe a bummer if they have to throw out an expensive pair that they just opened, but they really should discontinue use. They can resume contact lens use when the eye is not inflamed and they've not had any discharge for 24 hours. Right. Once that's all cleared up, they're kind of sure that the infection is starting to go away, and they go and put them back in. Any that were in use should be discarded. or if you can, disinfect them really well beforehand. And then also eye makeup can also be at risk for getting infected as well, cross-contaminated, so you have to worry about that reinfecting themselves afterwards. So typically tell them just throw out their makeup. Hopefully it wasn't something super expensive, but that's the recommendation. I don't know who actually does that, but. Okay, so any questions from this section? Yes?
Back on the slide where you talked about trimethicone,
Mhm.
the trimethicone solution. So does that always have to get combined with another drug?
It very frequently does. I believe there are some kind of single trimethoprim products, but very frequently you see it being given with something else. Yeah. Because again, it works better with that synergy there, so it's just very frequently added with something else.
On the chart where it was like gray and then highlighted yellow,
Mm-hmm.
you said there was a difference between the gray and yellow.
Yep. So the yellow ones you should definitely memorize. So on the so the question was the difference between the grayed out and the yellow highlighted slides. So on the antibiotic slide, know all of those because we talked about all of those. Those are all ophthalmic products. On the antifungal and the antiviral slide, only know the highlighted ones because we'll talk about those other ones in later sections when we talk about more systemic antifungals and antivirals.
And these are non-systemic?
Yeah, those are the ones that come as commercially available ophthalmic products. Yep. Again, when I say commercially available versus something that has to be compounded, commercially available means it's sold by a company in this dosage form versus something that has to be compounded kind of ad hoc. So like say, for instance, with the amphotericin that was on the antifungal slide, you can make those intravitreal injections, but someone has to compound it from the base product itself. You worry about sterility risk, and it's really kind of a big hassle. So really only like specialty like compounding pharmacies or compounding companies will do that, but there's no commercial entity that is producing that product in the ophthalmic form. That makes sense. Anything else I can answer for you guys? All right, so I'm gonna I'll upload this to the YouTube and put it onto the YouTube. I sound like an old man. I will upload it to YouTube and then put a link for you guys on the Blackboard site, and you can go back and review that if needed. So if not, I'll see you guys tomorrow.